This promises to be, I think, an excellent program. We have a very special program lined up this morning. The topic is controversies in sleeve gastrectomy, one of the most rapid growing procedures in bariatric surgery and general surgery. We have a special opportunity today to connect to one of the largest scientific meetings in the world on sleeve gastrectomy, the International Consensus Conference on Sleeve Gastrectomy, being held right now in New York City with Dr. Michel Gagne and some of the top experts in the world. So we will be connecting to New York in just a moment. I do want to acknowledge our participants who are signed on this morning. We have a number of folks from all over the world today. We have Anne Arundel Medical Center in Maryland, Carolinas Medical Center, Cleveland Clinic of Weston, as well as Cleveland Clinic in Ohio, of course, Dalhousie University in Nova Scotia, Canada. We have Geisinger Clinic, Imperial College of London in London, UK. We have Indiana University, Johns Hopkins, Lacanau Medical Center in Pennsylvania. We have McGill University in Canada, Medical College of Wisconsin. We have the Minnesota Institute of Minimally Invasive Surgery, Mount Sinai Medical Center in New York, Ohio State University, Sentara Lee Hospital. We have the Sheikh Zayed Medical Center in Israel. We have the Sheikh Khalifa Medical Center in Abu Dhabi, University of Maryland, Virginia Commonwealth University, and Walter Reed Medical Center. And how appropriate for Walter Reed to be on board, because this is Pearl Harbor Day, and we would like to acknowledge that, December 7th. Well, let me connect directly to our colleagues in New York, and I see my colleague Tom Rogala, who is there. And Tom, welcome.
Welcome, Phil. Thank you for joining us. I want to welcome everybody from New York City, from Marriott Marquis Hotel in Times Square, at the heart of New York City, from the 4th International Consensus Summit for Sleeve Gastrectomy. I want to introduce again course director, Professor Michel Gagne, who organizes this meeting every year, and it's a great forum for discussion about sleeve gastrectomy. We also have Dr. Raul Rosenthal from Cleveland Clinic, Florida, Dr. Luigi Angassani from Rome, Italy, Dr. Antonio Lassi from Spain. And we have here about 100 or more people on the room waiting for the discussion. I think we need to start. We choose several topics to discuss. Looks like the most popular question and topics was management of leaks. Phil, I would like to ask you, in your experience, what's the most rational management of leak? When you see leak, what would be the first step to do?
Yeah, Tom. Well, this appears to be an important problem with sleeve gastrectomy, and perhaps the leak rate may be slightly higher even than with the gastric bypass procedures. And I think what everybody can agree with is that when the leaks do occur, they can be devastating because they're very difficult to manage, and they often will result or can result in a long-term enterocutaneous fistula. So I think the first step is, of course, identifying the problem and quickly managing the patient, particularly operatively if the patient is not stable, if the patient has any signs of ongoing sepsis, then you go right to surgery and obviously control the sepsis, drain. Often trying to close the defect surgically is very problematic because of the associated inflammation. Putting a drain in place, and then hoping that this thing will not develop into a chronic fistula. Many surgeons will add a stent at the time, and there have been some studies showing some benefit in stenting and reducing the long-term fistula rate. But I would love to hear what some of the panelists there in New York think about how to manage these difficult leaks.
Yesterday we had a good demonstration during the live surgery session. Dr. Shwiyar operated a leak. This was a later leak. He did a fistula jejunostomy, Roux-en-Y. He's done a series now, I think, of 20 cases he described. It appears that probably acutely in the first 24 hours, if you can go back and close the hole with sutures where it's a really technical problem, that's fine. But after you pass 48 hours, then the sutures do not hold, and I think the stent is the way to go. But I would think that now with the fistula jejunostomy management, probably the stent will, you should try for a few weeks, close, go for a fistula jejunostomy early. There are people who even are thinking of doing this operation few days after a leak, you know. So we're going to have to wait more of the results of people who are doing this, but certainly chronically this operation works, the fistula jejunostomy Roux-en-Y. Acutely it's the stent, and somewhere in between we're probably going to have to switch to the fistula jejunostomy earlier than what we thought, because this causes a definite resolution of the problem.
Right, so it looks like internal drainage is the solution. Now, Phil, I know you did a couple of cases like this with internal drainage with the ruling. How difficult technically is to do this? I know it's very high up, usually the fistula. So how difficult is to do this anastomosis that high up? And how effective was in your experience?
Yeah, it can be quite challenging. I think the extent of difficulty is related to the amount of inflammation, as Michelle, was alluding to. And sometimes early on, there can be quite a bit of inflammation. If you do these operations, later down the road, several months, and when the inflammation settles down, it can be technically a bit simpler to do. But by no means is this a straightforward procedure. More often than not, what we have done is rather than just hook up a Roux limb, we've actually converted the sleeve directly, to a Roux-en-Y gastric bypass. I'm curious and I see Tony Lacey and Raul Rosenthal and Luigi there at the podium. What do you guys do? Raul?
Good morning. Thanks, Phil. I think when we look at leaks after sleeve, we need to look where they are, location, when they happen, timing, and the size. When it comes to timing early leaks in patients that are hemodynamically unstable, I would favor to put a stent and drain them laparoscopically. If they are stable and the leak is proximal and small, and they're well drained, I would just observe them and put them on TPN. The timing when to operate, if to operate, I would say not before 12 weeks, unless the patient is hemodynamically unstable. And after 12 weeks, what we choose to do is a proximal gastrectomy and esophageal jejunostomy.
Luigi, you have any experience with this early drainage?
I think I totally agree with Raul that the BMI, the size of the patient and the location of the perforation is very important. In my experience, the leaks I have treated, the very high leaks I have been treated conservatively with stent, while I was more aggressive on the distal leaks, and I did straightforward Roux-en-Y with the distal resection of the distal stomach.
So the question is, in this internal drainage, do we need to do a formal Roux-en-Y gastric bypass with a division of the sleeve, or just bring up the Roux limb and sew it on top of the fistula? What do you think, Michel? What would be the best?
Yeah, I think at least for us, to try to make a Roux-en-Y bypass, for us it's absolutely impossible because it's very, very high. And that is, you wanted to do another anastomosis like this. I think, they have to make a jejunostomy, a fistula jejunostomy. I think it's a good idea. On the other hand, the experience in my hospital with the stents is also a disaster. We put stents and other re-stents, and sometimes it's very difficult to take out, change the material of the stents. At the end, you have a patient 6 months trying to treat this patient, go to home, come back to the hospital. It's so expensive, and I think it's no doubt the best idea to try to do a surgery like a fistula jejunostomy or even sometimes a gastrectomy. We have a couple of cases operated in other hospitals with a fistula, with a bronchus, and it's so difficult operations.
Now, did you ever have to resect esophagus or with the stomach? And what do you do in these dramatic cases?
Yeah, in those cases we do, I'm sorry for that, but we do a total gastrectomy because we are not, probably I don't want to do a proximal gastrectomy in those patients because it's a problem with the reflux, and we normally do a esophageal gastrectomy. It's a simple operation for surgeons with experience, for example, in cancer, gastric cancer.
But Antonio, if you're going to do a roux and it's an esophagojejunostomy or a gastrojejunostomy with a gastrectomy, wouldn't it be just simpler to make the roux to the hole? I mean, it seems that the experience of those who've done it not had more leaks and had to really transform that to a bigger operation, because doing a gastrectomy or doing esophagojejunostomy, it's quite a big operation. As someone who's already sick, may have some sort of chronic abscess and so forth, the post-op is going to be much more stormy than if you do a side anastomosis, leaving everything intact, putting a drain on the side, and you're going to have two ways where the food is going to go. But as we've heard, sometimes they close, and then the natural pathway is still there.
If I may make a comment, because I'm an advocate in the proximal gastrectomy. There is no reflux because you're doing esophagojejunostomy. The problem in putting a loop up there is that you're going to create marginal ulcerations. Let's not forget that the whole stomach is still in situ. So in the long term, you will have to divide that. Mm-hmm. If you have an acute leak, you should not operate at all. I mean, in the emergency, to drain and to get the hell out there. So the question is what you do 12 weeks later when the patient is already stable, you have a gastrocutaneous fistula, and in those cases, to go and do a proximal gastrectomy with esophagojejunostomy sounds like a big operation, but it is not.
I agree with Michel. We don't have experience with the fistula jejunostomy, but at least in our patients, I would like to make a recommendation, because at least in Europe, many people is trying to, at the beginning, starting with the banding. And they now in Europe, banding is a disaster, and it's go down. But now many people is doing a sleeve gastrectomy without any experience in another type of bariatric surgery. And I think it's a mistake, because they normally do not good operation for this. They don't have experience, and they send to the hospitals. In our hospital, a patient after 6 months with 7 or 10 endoscopists, with 2 or 3 operations, with percutaneous drain, etc., maybe we are wrong. Maybe you say, okay, we try to put the patient in the best health condition as possible, and try to finish the problem. And finish the problem sometimes is to do a big operation. I'm sorry for that.
Thank you, Antonio. Phil, you have questions to this?
Yeah. Tom, I wanted to acknowledge you have about 20 other sites on board, and we'd love to hear how the folks in the UK are dealing with these challenging leaks after sleeve gastrectomy.
So can you hear us?
Yes, we can.
All right. Hi. So my name is Krishna Murthy. I'm a consultant upper GI and bariatric surgeon at Imperial, and I'm sitting here with my trainees from Imperial College as well. And thank you so much for this opportunity to link in with this great educational forum. To be honest with you, we haven't seen too many of these leaks in our center. So what I can only say is what I would do if I had a leak after a sleeve gastrectomy. The first thing I would do is stent the patient, because most of these leaks are high up in the gastroesophageal junction, as we've been discussing. I would stent the patient with a covered stent for maybe about 6 weeks to 8 weeks, and then remove, and at the same time put a drain in laparoscopically around the site of the leak, so I get a controlled situation. And then if it doesn't leak, I believe that because I'm also an upper GI cancer surgeon, I believe an esophageal jejunostomy would be the best option with resection of the sleeve remnant. I know there are a few skeptics with this particular plan, but I believe that, if it works in cancer surgery, then there's a good reason it should work in bariatric surgery as well for an indolent leak that doesn't close for at least 3 to 6 months.
Well, great, and I'm very happy to hear that you don't have any leaks. That's great, and your approach is similar to what Dr. Rosenthal had recommended, going straight to a sleeve, to a esophagojejunostomy, but differ from some of the other opinions. We appreciate your comments there. We're going to go to another site. Let's go all the way over to the Far East, to Sheikh Khalifa Medical Center in Abu Dhabi. And Dr. Nameri in Abu Dhabi, I believe, is there.
Yes.
And I believe this is one of the most common operations, actually, for bariatric surgery in the Middle East. Dr. Nameri, how do you guys manage leaks?
Okay, so thank you for the opportunity. I have with me here 2 of the consultants from the region of my hospital. And sleeve is not the commonest in our hospital, but it's the commonest procedure in the UAE. And we've seen our sheer number of sleeve leaks that we've had to treat here. And our approach is a little different. If the sleeve leak is chronic, like more than 12 weeks after surgery, I agree with doing an esophageal jejunostomy, even though we haven't had to do it. The 6 or 7 leaks we've treated here, we've treated them by actually going back laparoscopically, because our experience with the stents have not been very favorable. And we drain and then place a jejunostomy tube. And we utilize the jejunostomy tube for feeding, similar to any other leak. And we've had a very good response with that, usually in about 3 to 4 weeks in the hospital, and then another 3 to 4 weeks at home. All leaks healed, and none of them has actually turned to be a chronic fistula.
Well, that's excellent, yeah, and obviously, if you can be successful with that approach, that's certainly the way to go, and I think there's a general consensus, on that, drainage, putting in a feeding catheter, primary closure if possible, but what if this turned into a chronic fistula? How would you manage it?
I think if it turns to a chronic fistula, probably doing a proximal resection, like Raul said, an esophageal jejunostomy. We have no experience with trying to do a fistula to a ruler.
Great. Okay, thank you very much. And we'll get back to you guys in a few minutes. Let's go back to New York with Dr. Rogula. So, Tom, it looks like we've talked about sort of 3 strategies for managing these chronic fistulas. One is going, as Michelle pointed out, to a root drainage procedure right to the hole. Others have said convert to a gastric bypass. And as Rosenthal says, go right to esophageal jejunostomy. So there you have it. Maybe we can move on to another topic, Tom, and that is this operation here to stay? Do we really have the long-term data that we need to justify this as a standard bariatric procedure? And let's take it to the panel. What do you guys think? Tony Lacey, is this operation for real and ready to stay?
In our hospital, we normally do the 3 type of operation: the sleeve, bypass, and duodenal switch. The reality in the hospital, we operate because we have a special contract with our national government, because we have a national health system, and we operate 300 patients by contract, and normally now it's around 40% of them is operated in a sleeve gastrectomy. The indication of the sleeve is increasing, sometimes because the patient asking for this procedure. Sometimes probably it's related because before we don't have the sleeve gastrectomy, we try to do a bypass even in patients with a large left low liver. Now immediately we try to found any problem, any technical problem, we decided to do a sleeve. That is, my conclusion is that sleeve is increasing, but my question is, who knows in the long-term results, I'm talking about 10 years after, what will be the right operation for this.
Okay, thank you. I want to ask Dr. Gagné, you probably have a longer experience with sleeve. How those patients from the early days when you start doing this, how are they doing now, like 10 years after?
Well, as I said, the operation is going through an evolution of the way it is being done. And similarly, when the gastric bypass started, the pouch was not divided, it was horizontal, it was a loop, now it's a Y. So gastric sleeve also went through some evolution over the last 10 years. I think we're doing it tighter, better mobilization, hiatal hernia closure, closer to the pylorus. So if you're asking for 10-year data when the operation started, then the data is not as good as what I think is going to be with the way it is being done now. One of the long-term data is coming from the Cleveland Clinic, University of Pittsburgh data. I think it was super obese patients, 8 to 9 years follow-up or series. And in BMI more than 50, I think they had something close to 50% excess weight loss, between 40 and 50% excess weight loss, which is very good for super obese patients. If you look at this for morbid obese patients, the result is even better, but more around 60% after 5 years. And so I think very similarly to gastric bypass, you're going to have high failure rate in BMI more than 50. It's going to be a good operation for BMI less than 50. But the reality is that patients with BMI more than 50 are demanding this operation and want to have a shot at it. The other thing you have to remember is that the number of procedures in the States has plateaued. And that's with gastric bypass mostly. So the problem we're having is that there are millions of people in the United States who need the operation, and we can do 2 sleeves in the same time as 1 bypass. So if we have a limited manpower, we could probably do more treatment, and I believe there's less complication because the American College of Surgery database shows that the mortality and the morbidity is less with gastric sleeve than with gastric bypass. And remember, the long-term minerals data and all this in gastric bypass is not out there compared to what we're going to have in the micronutrients deficiencies. So I think the operation is going to hold. About probably 1/4 of patients will need a revision.
Yeah, I was just going to add briefly to Michelle that currently there, to my knowledge, only 5 studies published that have 5-year or more data. And Michelle commented about our study, and I do want to give George Ide at the University of Pittsburgh credit. He really did all the work in finding these people. This was our initial series that we published many years ago and had to track these folks 8 years after the procedure. And Michelle's right. There were higher BMI patients. The average BMI was actually 65 in that group, and the intention was to actually do a second stage, but these folks stayed with the sleeve as their primary procedure. And Michelle's right. At that time, we were using a larger bougie, a little different technique, and even despite that, the excess weight loss wasn't bad. It was about 48% with an average follow-up between 6 and 8 years. And all the other studies seem to show similar long-term weight loss in the 50 to 55% range with an earlier sort of rendition of that particular procedure. Any of the other panels have any comment about the long-term follow-up of these procedures? Dr. Rosenthal.
Yes, thank you, Phil. I think that when we measure success of surgical procedure in bariatrics, it's not only about weight loss. We need to also balance morbidity and safety. I think the sleeve gastrectomy is by far the one that has the less morbidity, number one. You can say, well, 50% of our sleeves are going to regain weight and might need a gastric bypass. I don't see that as a failure. I see it as a success still because I save 50% of my patients from having a gastric bypass, and we know well it's a morbid procedure in the long term. So overall, answering your question, I think not only the sleeve is here to stay, at least in our practice, it's 50% of our procedures in 2012.
Thank you.
I may make another comment. I totally agree with what Raul said. And the other question is that we have a lot of operative complication after gastric bypass. We have internal hernia. in bowel obstruction that need reoperation, and this is basically the revision rate for technical complication of sleeve gastrectomy is very low. And the other thing is that the operation is going to stay because the others are not convincing to me. Banding is, as we already talked about banding, but bypass is a very nice operation, but in my experience in southern Italy, only 20 to 30% of the people I operate are still taking medication 10 years after the operation. And this to me is a terrible problem. These days when I do a bypass, I always think what is going to happen to this patient in 10 years in spite of the weight, but this is a very important topic that I hope we are not going to have with sleeve, because this is another problem.
Well, we have another questions from International Bariatric Club members. Dr. Mohammad Talambur from Iran. He's one of the pioneers of gastric plication. He's asking if rate of weight regain is higher after sleeve comparing to gastric bypass. I think that depends on initial weight, initial BMI, and many other factors. But what do you think, Michel?
I don't know the question, this answer beyond 5 years. What we know is there is one randomized study that is beyond 5 years. That study is from Greece. It was published in the Annals of Surgery with the 1-year data, which showed better weight loss with the sleeve than with gastric bypass. But it was not statistically different. The difference was 6% in excess weight loss. By the year 3, it was still higher with the sleeve than with bypass. And by year 5, they were equal, not statistically different also. So we need that sort of evidence, study to really make an answer. But I truly believe the problem and the psychological perception is that when a patient failed weight loss with bypass, these patients are not revived. They are rarely revived, and we tell the patient, it's your fault. You're taking too much liquid calories, or you're not doing exercise or something, because we don't want to deal with these patients because we are stuck. With sleeve, we're going to say to the patient, oh, you're gaining weight? Okay, I'm going to transform to a bypass, or I'm going to do a gentle switch, or I'm going to do a re-sleeve. We have options. And I think that's why we're going to see a lot of papers of revising sleeve and not so much on revising bypass, because it's still a nightmare to do that.
Raul, what's your experience?
I just want to add, I don't think it is fair to compare the bypass to the sleeve at this stage. Bypass has been done for nearly 15 years or longer. Sleeve gastrectomy is in evolution, and we're looking at 10 years. We started with bougies of 48. We are now to 38. So I think we don't have the 10-year data to compare it to the bypass. And as we know, bypass is an operation that has so much variability, the size of the pouch, the length of the limb, the size of your anastomosis. So I don't think it's comparing apples and lemons. I wouldn't compare that.
Phil, how would you address this question from Dr. Talambur? In your experience, the weight regain after sleeve comparing to bypass?
Michelle pointed out, we only have a lot of long-term data. The only way to fairly compare this is with, prospective randomized controlled trials. But if you look at the collection of observational data with the gastric bypass, and there's probably a dozen studies that go out to 10 years and beyond, and you're looking at excess weight loss in the 60-65% range. And we just haven't seen that with the sleeve. So it remains to be proven, if the sleeve can maintain that type of long-term weight loss. Tom, I do want to go. We have a question from Carolinas Medical Center in North Carolina, and I do want to go to them so they can make a comment or question. Let's go directly to Carolinas Medical Center.
This is Dimitris Stefanidis, and I want to thank all of you for an excellent panel and presentation. We haven't had a lot of experience with leaks. We've done over 300 cases among the three of us, and we haven't had a leak yet. But I did want to ask the following question. What is the role of prevention? What does the panel think? Are there things surgeons can do to minimize the chance of leaks, not just treat them after they have them?
Let's hear from the panelists regarding preventive strategies.
I think that the first thing is that people are trying to get too good results, so they ended up making a too tight sleeve, and they're using a too small bougie. So I teach a lot, and I say people don't use a quick frame. It has to have adequate lumen, and you should avoid getting a stricture. Stricture is equal to a lot of problems in the sleeve, including leaks. We use much more compression than what people are telling us to do. We use compression time. The total is almost 1 minute for the whole stapler. And so I think that these maneuvers are important. Also, avoidance of the incisura. Incisura is probably where the sleeve should be the widest. And also use some sutures, absorbable sutures when it's bleeding, and avoiding cautery and clips. Clips, I think, are a disaster when we reoperate on these patients because they get in the way of the stapler if we do revision surgery. So I think that these are strategies, at least intraoperatively. I believe that a lot of the leaks are caused by intraoperative things that the surgeons do, so they have to review what they're doing at their surgery.
Raul, what's your opinion?
Yeah, I think I endorse 100% what Michel just said, but Dimitrios, tension, tissue opposition, distal obstruction, ischemia, and bleeding are the 5 main factors you're going to have in gastrointestinal surgery while you're going to have a leak. And sleeve gastrectomy is the longest staple line we have in general surgery, probably in surgery at all. So I think to avoid bleeding from the staple line is important because those hematomas might end up becoming, a leak. Avoiding distal obstruction, as Michel said, the incisura angularis. Don't try to overdo it to do the narrowest sleeve. Avoiding torsion because that will create also more intragastric pressure and distal and proximal disruption. But I think these are the 5 things you need to avoid. Leaks are due to technical errors. I agree with Michel.
Luigi, what's your opinion?
Only I have used a lot of reinforcement, and after some time my hospital didn't buy any more reinforcement, and I had to stitch. And I think I do an inverted stitch all over the rim of the staple line. I think that I don't trust staple line without anything. I would advocate stitching or reinforcement or whatever.
I've got a question to Phil and Michel. From what I remember, you both treat differently the very proximal, the corner of the sleeve. I remember Dr. Gagné was dissecting very thoroughly the angle of his, and Phil is trying to incorporate the corner and oversew. And the question is, would that incorporation and leaving fundus a little bit longer might regain weight?
No, I think that probably for the evolution of what we've seen, I think leaving a small amount of fundus is a mistake. What happened is that you have a narrow sleeve mid-portion, and therefore that increases the pressure, and with Laplace law, that little triangle stretch, and I think that's because that's why they leak often. Right. Either it's some sort of a triangle, the way it was shaped, a very acute triangle that distends, and then the staple line disrupts in this area. I think you got to go into the angle. I think at the beginning we said go away from the angle. I think that we have to go back to the angle because that prevents, I think, decreased reflux. The Munich group showed that when the stapling is close to the G-junction, the lower special sphincter pressure goes increased by 2.5-fold, which then, really decrease the amount of reflux. When we are far away from the stretches, it increases the risk of leaks from the staple line, and it also stretch the lower special sphincter to cause reflux, in my opinion.
Phil, how far are you going from the corner, and how much of the corner is incorporated?
Yeah, Tom, I have to say, this is what Michel is saying is a departure, I think, from what I have. What Michel is saying is a major departure from what has been taught about this procedure for the past 5 years. Most surgeons teach that you should stay away from the angle of His the GE junction, and that's the danger zone. There's problems there with ischemia, higher pressure. Most surgeons teach to divide on the greater curvature at least 1 to 2 centimeters away from the GE junction or the angle of His. That's what I have taught. And I oversew, and I actually try to dunk that corner in. So in addition to a staple line, I have a serosal layer, and I do it so that I'm not encroaching upon the GE junction. I think that's a principle that has been long-standing in surgery, to have a serosal layer coverage. But the fact is, these are opinions, folks. We don't have clear level 1 evidence to say Michelle's theory is better than mine, but we have just long-standing principles. I'd like to hear what the other panelists say about that critical last staple fire. Raul, what do? Don't you go away from the angle of His?
Yes, I do. The surgical answer is very, very clear and short.
How far are you going away from the angle of His? It's like 2-3 centimeters. How far are you going away?
I don't touch the lateral fat pad. We have now over 800 sleeves, and we had one leak at the very beginning of our experience, and we didn't have leaks with primary sleeves anymore. And I always stay lateral from the fat pad, and I know that some people advocate dissecting and moving that fat pad. I'm scared to look at that fat pad alone, because I think there is a leak hiding there under the fat pad.
Let me answer back and ask Phil, when he does his pouch for gastric bypass, how far are you when you do this? I see these guys putting a, what do they call it, Fauchet tube or a tube, and they staple around it. And definitively, they are probably in the angle or even inside the angle, and then they don't get leaks there. So how is that possible? And we get leaks, in sleeve gastrectomy. I think that one of the problems is that we're going too far away from the G junction, and that creates these triangles that are really getting ischemic.
Go ahead, Phil. Last comment on
this.
Yeah,
let me just briefly answer the question, because I think we're getting close to finishing, Tom. And I know that the group in New York has to start their program in just a few minutes. But, the gastric bypass, I do the same. I'm about 1 centimeter distal to the angle of His and making the gastric pouch. I think the bottom line, Michelle, is we don't really know the clear answer. It's only speculation to say which of these has a higher leak rate. We have to just go by, standard principles. And most importantly, expect that sooner or later you're going to have a leak. Don't fool yourself into thinking that your technique is perfect. Early intervention is the key, and wide drainage. And some of these will end up with a chronic fistula. And you've heard these 3 different strategies that have been put forth by the experts that seem reasonable to recommend. Tom, I think we have to close. It is, we're a few minutes late. I do want to thank the panelists there in New York, and I regret that I can't be there, but I understand this is going to be a phenomenal program, Michelle, and over 500 or 600 people attending, and I'm so glad that you let us participate. I also want to thank our audience that participated. There was some 200 or 300 members who were involved in these 20 or 30 sites that are connecting this morning. Thank you for your comments as well.